Amsterdam UMC, and I'm doing, she's hidden here, but Brooke is my supervisor. And yeah, today I guess I'll just share a little bit about some of the modeling work we did with WHO for the TPP. I don't think I need to sort of explain to anyone here why TB is a problem. I think everyone knows, but I guess just highlighting in terms of the NTB 2025 goals, we're not really on track to meeting them. And in 2023, we still had quite a large gap in diagnosis, approximately 25%. And of course, we have continued transmission within this group. And a lot of the diagnostic challenges come down to things like inappropriate screening tools or diagnostics, and not having enough of them for the different stages of TB or for all the groups of individuals. There's also limited access to testing. Either testing is unavailable, or it's unreachable by patients, or it's unaffordable. And not all individuals with TB have symptoms for which they seek care. So really, because a lot of diagnostics is still quite passive, there's a need for some more active case finding. So I think with the need for new diagnostic and screening tools, the target product profiles have a chance to sort of guide the development of these, guide what's needed, how things should, or what things should cost, how different tests might be implemented. So we were working with WHO for these target product profiles, and they're generally documents which are released every few years. The last iteration of TB ones were done in 2014, so I think they were due for an update, but often provide minimum requirements in terms of sensitivity or specificity, the sample type, turnaround time, just to name a few. And in this update of target product profiles, it's one of the first times in which modeling has been incorporated into the process. And that's really to help decision makers sort of with a starting point. Generally, a group of experts sit together and they decide on what these values should be. So modeling in this case was just used as another piece of evidence to support that process. And in terms of our role in the modeling, we were working with WHO on 2 TPPs, the diagnostic TPP, which has come out this year, as well as the screening TPP, which hopefully will be published next year. And in the end, there were 2 quite different TPPs, and we had to take quite different approaches when we were working towards the modeling for them. I think one thing, we've sort of built a generalized approach for our TPP modeling, some of the key steps, essentially defining what elements we wanted to model, our key modeling concept, any comparators or constraints that we could use, our different modeling scenarios, and then of course simulating the scenarios and determining which meets our inclusion criteria, and then taking these results and turning them into something for the TPP itself. So to start with, I'll look at our diagnostic TPP modeling. So we were asked by WHO to sort of help with defining minimum sensitivity for different TB diagnostics. We were guided by them on what specificity should be, so we were really focused on sensitivity alone. In our modeling, we were looking at 3 separate countries, and this was to get a little bit more of a global perspective than just looking at one. We looked at South Africa, Kenya, and India, and these were selected in conjunction with WHO, just because of some of the differences in terms of the patient journey, the type of diagnostics being used. So for example, South Africa at the moment uses predominantly gene expert, whereas in other countries, there might be more of a mix between smear and NAT, as well as different HIV, TB co-infection burdens. And overall, we were looking to quantify the potential impact that new diagnostics could have on the current standards of care in each country. And in this case, our impact was looking at the change in the number of individuals with TB correctly receiving a diagnosis. And throughout this, and I think something that we've had a lot of discussion about after the TPP process as well, was this concept of accuracy versus access. So we have a diagnostic which is more accessible to patients, or that shortens the time or the number of visits before receiving results. Are we able to diagnose more people even if the test is lower accuracy? So just a pictorial example here. On the left, we have a lower accuracy, high access test, as compared to the high accuracy, lower access version on the right-hand side. And even at the lower accuracy, the difference in access still allows us to diagnose more people. And throughout the modeling, this access parameter is sort of defined by aspects like sample type and healthcare setting and how quickly results can be returned. But before even getting into an understanding of the impact of these other diagnostic attributes, we need to know where our gaps in the cascade sit currently. So there's several elements where we may lose people in the diagnostic process, or where they may not end up going through their entire journey. So the first one is individuals might not seek or cannot reach care. This might not be something we can change with diagnostics, but it's important to acknowledge. The next might be that testing is either not offered when it's indicated, or perhaps an appropriate diagnostic is not available to people. If testing is centralized, perhaps samples don't reach the labs, or people have to move. Maybe people don't make it to the next facility, or results may not be returned to the clinics, or samples may be rejected. And the last one is anytime a patient has to come back to the facility, there's a chance that they don't. So if results are not available right away, perhaps not everyone comes back to receive those results. And with these three gaps, we looked at how potential diagnostic attributes, so other than performance, might close them. So for example, the first loss, non-sputum tests, perhaps they're easier to offer, so more people get offered testing. Or perhaps for people who are HIV positive and can't produce sputum, this might be a more appropriate sample type. If we did testing on site, it would mean that samples don't have to move, or patients don't have to move. It's easier to get samples tested. And if we had results in the same clinical interaction, so a true point of care test, it would mean that we wouldn't need another visit for people to come back and collect the results and start on treatment. So these are generalized gaps, and they exist differently across countries. So when we went about our modeling, we looked at defining some baseline cascades for each of our countries. And it's quite a lot in this figure. But essentially, we wanted to answer some key questions. So where are we losing people? Where do those three losses sit? How do we parameterize this cascade? How do we calibrate it? What population characteristics do we want to include? What diagnostics are currently in use and in what proportion? How many visits do patients have to make? Are they referred between facilities in their journey? And in the end, we're wanting to know how many people receive a correct TB positive diagnosis. And if we were to fit a new diagnostic with different attributes, how would it change the patient journey? So just as an example, in this one, we start with a target group. We've assumed them to be symptomatic TB patients. Some of them seek care, some of them don't. Some can provide samples, some can't. And for example, a non-sputum test might cut this group out. If everyone is able to provide a sample, we don't have any loss or additional visits required to provide that sample. So potentially the right-hand side of this cascade might be removed for diagnostics with non-sputum samples. Similarly, if we had a test that returned results in the same clinical encounter, we might not have to have this additional visit made by patients in the end. So with this in mind and mapping out, I've only shown South Africa here, mapping out these journeys for each country, we tried to define 6 scenarios that we could look at. And in this case, we had a baseline scenario, so mapping out what we believe is an average patient journey from symptoms to diagnosis in each country, and then looked at 3 sputum scenarios and 3 non-sputum scenarios. And then additionally, we had different technology classes. So we might have a low complexity class that would be something considered like NAT testing through GeneXpert. We'd have near point of care, so tests that are taking place at the facilities, but don't necessarily return results in that encounter. And then true point of care tests also take place at the facilities and return results at the testing visit. And for each of these scenarios, we applied these diagnostic attributes, looked how they changed the cascade, and then assumed a test with a performance of 98% specificity and ranged the sensitivity, and then simulated what our results might look like. So as a first example of the results, on the x-axis, we have different sensitivity, and each of these lines represents one of our 6 scenarios. And the dotted line represents the base case or the baseline case in the country at the moment. And what we were looking for in these scenarios is a case where we had equal or better performance in a scenario. So essentially, at any point where our scenario lines intersect with baseline, that means we're diagnosing the same number of individuals as we currently would be. So any sensitivity below this intersection point for a scenario would have worse performance, but any sensitivity equal or above would have improved performance. So we looked at this across countries and for each of the scenarios. And what we generally see that as we move from our lower access, so maybe our light blue lines, to our highest access scenario, the green line, which would be our non-sputum point of care tests, the minimum sensitivity requirements across the countries decrease. So for example, in South Africa, our baseline, we may need 90% sensitivity for a sputum low complexity assay, but we could go to somewhat below 70% sensitivity for a non-sputum point of care and still find the same number of individuals in the model. So across this, what we saw is that diagnostics which bring testing and results closer to patients can have lower test sensitivities. So as long as the diagnostic diagnoses the same number of individuals as baseline. The question then was, how do we turn this into something we can share in the TPP? We started by pulling out those intersection points across our countries and our scenarios. We do see that the results differ by country, and that tends to come down to what the standard of care is there now. So for example, in scenario 1, South Africa had the highest minimum sensitivity requirement, 91%. And that could come down to the fact that South Africa predominantly uses expert for testing, which is considered potentially more accurate than smear microscopy, which is still in use in India and Kenya to different degrees. So the requirements to meet that performance have to be quite high. We also saw an interesting shift in the highest sensitivity requirements between our sputum and our non-sputum scenarios. So for example, India, where the proportion or the percentage of people with HIV, TB co-infection is lower, there might be fewer gains with a non-sputum sample as compared to a country with high HIV, TB co-infection, just because not as many people will be unable to provide a sputum sample if there's low HIV. So with these results, we then considered across a scenario and across the countries what the highest minimum sensitivity would be. So example, scenario 1, the highest was 91%. Scenario 6, the highest was 70%. And the reason for choosing these highest minimum values was to ensure that there was no harm done across any country. So if we had 91% in scenario 1, South Africa would see equal performance to now, but we would see gains in India and Kenya. So in the end, these were our 6 values, which we submitted for TB consideration. It doesn't necessarily mean that those were the values that made it into the TPP, but our modeling worked to share these 6 values with the WHO TPP Development Group. And just in summary for the DX modeling, we were looking to define minimum sensitivity for diagnostics with different attributes. We were modeling access versus accuracy on the number of individuals being diagnosed. We defined baseline cascades for our 3 countries and used these baselines to generate comparator values. We defined our 6 scenarios looking at combinations of sample type, site of testing, and turnaround time of results. We generated our country-specific results for individuals at different sensitivity levels for each scenario, and then looked at our highest minimum sensitivities to define our TPP elements. So in the end, we did quite a lot of modeling work for these or for this TPP. And it's perhaps a little more complicated than the actual analysis we did for screening. But coming up with the way we went about screening was actually quite challenging. And that comes down to there being quite a lot of key questions and challenges to do with TB screening. So how do we determine what a feasible and acceptable test is, given that we don't have a single sort of comparator tool or baseline to evaluate against? In this TPP, we were wanting to consider asymptomatic populations. Screening can occur for a range of different target groups, each with potentially low but different prevalence levels. Screening can be active or passive or facility or community-based, each of these having their own constraints, requirements, cohort sizes. There are multiple implementation algorithms for screening. Is it happening in parallel? Are there multiple screens? Are they in series? What comes after screening? And as well as how do we manage the potential impact of a screening program on the standard diagnostic cascade, given that screening usually needs to be followed by confirmatory tests. So there was a lot to think about, and we went quite back and forth quite a long time with WHO on how to approach this, went through different versions of our modeling. And in the end, it was a relatively simple analysis to implement, but yeah, complex to think through. So what were we wanting to model? In this case, we were looking to model sensitivity and specificity requirements for novel screening tests in low prevalence settings. So in our modeling, we looked from 0.1% up to 1%. We did a simple decision tree analysis looking at the performance of a novel screen followed by confirmatory tests for 100,000 individuals. So in this case, we haven't considered any aspects of loss like we did in the diagnostic modeling. Because we had no clear comparator or no baseline to compare against, we defined alongside WHO 2 prerequisites for an acceptable test. So we would need to have at least 5% or at least a 5% post-screen prevalence achieved. So at least 5% of people who screen positive must have TB, and a case detection rate of 60%. So what this looked like, if we start with a prevalence of 1% and our 5 orange dots are people with TB, they'd be screened with this new novel screen. In the screen positive group, at least 5% of people must have TB. And after the confirmatory test, which we modeled as a Gene Expert Ultra in this case, at least 60% of our people with TB, so 4 out of our 6 dots at least, must be diagnosed. And in conjunction with this, what was different about screening is that we were modeling sensitivity and specificity. So we had 2 moving values. So to try and limit that and only look at one value at a time to sort of not have too many combinations, we defined 2 types of test class. So a high sensitivity test. So here we would set sensitivity at 90% and range specificity. And perhaps a bit different for conventional screening tools, we also defined a high specificity test. So set it at 98% specificity and then ranged sensitivity. And we also ended up considering 2 different screening algorithms. This came throughout the modeling process where we learned in some cases one screen was insufficient. But in this case, it was either one screen, so our novel screening test followed by a molecular confirmatory test, or a 2-screen approach where we had a novel screening test and we modeled it as being followed by a chest X-ray and then confirmatory testing. So these are sort of what our algorithms looked like. I think one thing that's important to point out is that we used in this case chest X-ray as a placeholder. In the future, this could exist with any other type of test. And in this modeling, we modeled novel screen followed by chest X-ray. Mathematically, at the end, the requirements would be the same if we modeled it as chest X-ray followed by the novel screen. Although in implementation, the order in which you do the tests would be quite important because it would change sort of the size of the groups being screened in each case. So it might be more of a cost consideration then as well. Looking at the results from this analysis, so starting at how we presented our post-screen prevalence. So on the left, we have a high sensitivity test. Each of the colored lines represents our prevalence, and the solid black line represents our 5% threshold. And we looked at different specificities. At what point would we reach this 5% threshold? So what we saw is that for low prevalences, 0.1% and 0.25%, we wouldn't be able to reach this threshold in a one-screen algorithm. At 0.5%, we'd still need a specificity greater than 91%. For the high specificity test on the right-hand side, we saw that this post-screen prevalence was easier to reach generally. We couldn't quite get there in the 0.1%. But for the other three prevalences, the sensitivity requirement was quite low. But post-screen prevalence was not our only constraint. We also looked at case detection rate and included here the number of tests we were doing. So here in light green, we have the total number of confirmatory tests being done. In dark green, our cases detected. And the black line represents the case detection rate at each stage. So for example, here, to meet our 60% requirement, we would need a sensitivity of about 68% in this case. So these were how we went about collecting and presenting the results. I think looking at each combination of algorithm and test type now. For a high specificity test in a one-screen algorithm, as I mentioned before, to meet post-screen prevalence, we don't need too high sensitivity in most cases. The requirements really being controlled by this case detection rate. So what we could see in the end is that we can't meet both constraints in a 0.1% prevalence. And to meet the case detection rate criteria, we need a 68% sensitivity. So that was the minimum sensitivity required for this one-screen algorithm high specificity test. And one thing before moving on to the next slide that I'd like to point out is that for a high specificity test, the highest number of confirmatory tests that we might get up to is around 3,000 for a population being screened of 100,000. And if we looked at a high sensitivity test, those numbers can really be quite substantially different depending on what the specificity is. So that's one thing to consider is how would that affect our diagnostic cascade afterwards? We could maybe accept lower specificity according to our constraints, but the knock-on effect of how many diagnostics there need to occur afterwards could be quite substantial. But in terms of the one-screen high sensitivity test, the case detection rate criteria was not really something we needed to consider. It was 81% across the board, so that met our 60% requirement. But here, the post-screen prevalence really determined what the minimum specificity would need to be. And we weren't able to reach it in a one-screen algorithm for the 0.1% and 0.25% prevalence levels. And in the 0.5%, we'd need 91% specificity, and in 1% prevalence, 83% specificity. Similarly, for the two-screen algorithm high specificity test, post-screen prevalence not really making any impact on our minimum sensitivity really comes down to the case detection rate. And across all our scenarios here, we would need 80% sensitivity. And lastly, our two-screen algorithm high sensitivity test, mostly controlled by the post-screen prevalence constraint. We can just reach it for the 0.1% prevalence, but this test accuracy generally would need to be very high. So about 96% specificity and 90% sensitivity. So this is almost in the diagnostic range, actually. But across our prevalences, we could go from requirements of 96% all the way down to 50%. So just summarizing these, for 0.1% prevalence, we weren't able to do this in a one-screen algorithm. We could for the two-screen algorithm, but we may need quite high test performance. And generally, as our prevalence increased, the requirements of the test did decrease. The thing with this, though, is it's still quite a lot of values to look at. But I think that's both good and bad. It makes it hard to sort of pick a final test, but it also leaves it quite open for manufacturers to sort of see which range they might be able to develop something in. But in terms of turning these values into something for the TPP, these might not be the final ones. And there was a lot of discussion with WHO into what should be included. In the end, only 1% and 0.25% prevalences were considered for the minimal and optimal criteria. And we also did slightly different iterations of the analysis with different sensitivities for the high sensitivity test, so 90% versus 95%. And in the end, we only considered high specificity tests being used in a one-screen algorithm and not in a two-screen algorithm. But these final results and the final values included in TPP should come out shortly, but they do differ slightly across our TPPs from what our initial modeling results suggested. And for our screening TPP, so again, we were looking for sensitivity and specificity in different screening contexts. We were modeling the impact of this test on post-screen prevalence and TB case detection rate. It's quite a simple mathematical analysis to do, but our key constraints were 5% post-screen prevalence and 60% case detection rate. We had two algorithms, one screen versus two screen, and two test types and 4 prevalence levels. And these were used to define our scenarios, and we estimated our different prevalences, post-screen prevalences and case detection rates, and used these to define what our minimal and optimal cases should be for the screening tests. And I think just to end, it's nice to sort of contextualize this within the TPP process. I found it quite interesting to be a part of, and in the end, the modeling was only a very small part. And I don't think it was intended to solve all of the values of the TPP, but rather just to provide an additional piece of evidence to the people making the decisions. And it was a large group of people, of experts that came together and decided on the final values. And overall, the modeling was iterative. We did have a chance to present several times to the initial TPP development group and the full writing group. And I think that was really important to have those presentations, to chat to the stakeholders throughout the process. And that was one, to get feedback and adjust the modeling based on expert opinion, but also to get buy-in from the people making these decisions and to contextualize the modeling. So rather than waiting till the end and throwing a couple of numbers at them and saying, you should use these, we really tried to get people to discuss with us and have their say in what the modeling sort of followed, and allowed them to understand where it was coming from. And as I said, it was only a small part. And just also, I found it interesting to see how, I guess, lengthy and in-depth the TPP process itself is. It's initially drafted, and from there, understanding what sort of requirements are needed, what values are going to be included, where the modeling can assist with some of those values and what type of values. Once all that's included, it's shared with the initial writing committee that's revised based on comment, then goes out to the full development group, and they go through a Delphi process and provide feedback. It gets revised, it gets shared with the public. It gets revised again, and then eventually the whole TPP development group sits together and, decides that these are the final numbers, and then it gets revised and finalized again after that as well. So it's really quite an in-depth process, and it was interesting to be a part of and to provide modeling. It's one of the first instances being used in this process. But thank you so much for listening, and of course, always acknowledge everyone that was involved. And happy to take any questions.
Brilliant. Thank you so much, Alexandra. It was really a lot of detail there and really helpful to hear about. Thank you. Really great work. Congratulations. I have a couple of questions, but I don't know if anyone else. Hang on, I see something in the chat. Okay, a message from Sarah to say thank you for presenting your results. Does anybody have any questions? Sandy?
Yes, actually, it is really interesting work. I never had seen this kind of analysis. It is, I feel very great actually by attending this seminar. So, for clarifications, I didn't get the point clearly. Uh, for the diagnostic algorithm, to find the threshold condition, you have chosen three countries, right? Means
Yes.
India, Kenya, and another one. But for the other algorithm, for the next one, for screening algorithm, that is quite difficult. You have chosen the prevalence can varies from zero point 0.1 to 1% within that range. So I'm thinking means if you choose any other country, means you have for the diagnostic algorithm, three countries give you the threshold conditions, means from say with different characteristics that could give another value, right?
Uh,
So how to determine that from these three countries only you are determining that this is the threshold. So how can you justify that means?
I think, yeah, that's an excellent question. Yeah, you're correct in that each of the countries can differ quite substantially in terms of the implementation and the diagnostics being used. I think we were limited by how many countries we could include because of how different they are. In the end, we decided on these three in conjunction with WHO. And our hopes were that by choosing three fairly different countries, we might try and capture quite a lot of these
Yeah, of
different.
course.
Um,
Mhm.
but yeah, ideally, you would be able to include.
No, if you add many countries, then it would be, of course. But I think this is different varieties of countries where HIV is prominent. Some in some country HIV is less, so it's okay. So I was curious about. Okay, thank you, and very nice work.
Thank you very much.
Would love to see the paper.
The diagnostic one is out. Happy to share that with you. Screening
Yeah,
is
I will check.
better.
I will see that right now. Yeah, you'll find it. Thank you.
Thanks, Sandy. Um, I had a question around uncertainty. So you didn't include uncertainty in your in what you showed in the results, and I presume because for a lot of those ones, a lot of the uncertainty would be really overlapping. It would be quite difficult to kind of disentangle what's going on there. Um, but I presume from the way you described it that you did have uncertainty in your results. Um, yes, I just wondered if you wanted to comment on that.
Yeah. I think in our paper we do explore it a bit more. I think throughout the modeling, the parameterization um, was the most challenging. A lot of the values uh, are not always reported on necessarily, especially the patient journey characteristics are quite difficult to get to. Um, so we did have a look at which sort of factors are affecting um, our results the most. And I think particularly some of the assumptions as well about how different diagnostics would affect our patient journey. Without having them, it's been a little more tricky, or we had to make some assumptions on what those effects would be, just because they don't exist yet, so we can't evaluate them.
Yeah,
Uh,
absolutely. But I was just so I was thinking about you had things like where you concluded that sort of 91% was the um I've forgotten if it was specificity or sensitivity, the sensitivity. Um, but did you have uncertainty around that? Because I think you could get it from the way that you do it, I think. And it would be helpful to know, if it's between 80 and 95 or if it's sort of between 60 and 99 or something like that, just to have an idea of uncertainty in some of those values. I would assume for the what's it called, for the WHO process.
In the end, I don't think we reported on a range for the TPP itself in terms of those requirements. Because of, I think, all the moving parts in the end, we sort of needed to select values in conjunction and use those to come up with the final values that were suggested. And again, the values that also we suggested were further discussed and adapted slightly during the TPP process as well.
Yeah, in TPP documents, they never have uncertainty. So you have one value that you evaluate against, and that's it. So it's sort of your best guess, and that's what goes into the document. So it's quite different, right, than academia and showing all the possible uncertainty that exists. You have to pretend to be certain in this kind of a situation, which is very strange space.
Yeah, fair enough. Okay, cool. Thank you. If there's no questions from other people, I guess I had another one, which was, so you didn't, oh, sorry, Mary, do you want to ask? I've already asked
Oh,
once.
sorry, not to interrupt. I just had a thought. What is the setting for the screening TPP? Because there used to be a triage TPP. And I heard that they're kind of renaming triage now to be screening. But you were showing prevalence of like the highest was 1% and then it went down. So what kind of population or setting is that used for? Like, is it active case finding or prevalence surveys? Like, just to get a sense of where it would fit kind of in the flow or patient, whatever pathway.
Yeah, I think this one was really intending to sort of, I suppose, go towards more active case finding, really looking at maybe even asymptomatic populations. So that would be very active case finding and low prevalence in particular. And we did look at, I think, prevalences which were a bit out of the norm from what we've maybe seen in some of the WHO work before.
In some of the discussions, they wanted to say, okay, if we were to go set up, community screening and have one point and screen everyone that walks by, let's say, what is sort of the lowest prevalence we'd want to be able to do that in? And so they decided, well, we want to be able to do that in 0.1% prevalence, and then quickly found out that that would be an enormous challenge and require a hell of a screen to be able to achieve that. So, which was interesting to watch people realize that in real time.
Yeah. Interesting. Okay, thanks.
Thanks, Mary. My question was just if I was interested, so you didn't include costs at all, but some of these, you were talking about, particularly for the diagnostics, reductions in patient journeys and things like that. So I wondered if you have plans to do that in the future, because that feels like something I presume, I know nothing about diagnostics, but that I would assume would be useful for developers, partly to show, that this could reduce costs, but also then to think about how they pitch their the pricing on the tools that they develop and so on, if it's going to, under what circumstances it will be cost effective or cost neutral and so on.
Yeah, I think that's an excellent point. We were part of some of the cost discussions in terms of the TPP as well. As you say, it's a really tricky thing to try and define because you want it to be high enough that developers are still interested, but low enough that it's feasible for people to implement. So it was quite a lot of back and forth. I think we had initially started with some modeling where we were trying to look at cost, but it quickly became a little bit challenging for the TPP. I think it is something we'd like to explore a little bit more in terms of looking at cost effectiveness, and especially as we maybe sort of are getting to some diagnostics that, people are starting to use non-sputum samples for them. And as we start to see a little bit more about how they're actually implementing, I think that will also help with some of the cost effectiveness and sort of reutilizing some of these models.
And they had asked us initially to do those cost effectiveness analysis as part of this, and we did. And they said, okay, we want a cost effectiveness threshold of $500 per DALY averted. Cool. But then you could actually afford, like, if that's your threshold, you could afford to pay quite a bit for diagnostic, and that's not good for us. So then we said, well, what about a budget neutralization approach? Which we then gave the numbers from, and they're like, well, those costs are still too high, and we don't like that. So it started with some kind of science and methods behind it, and it turned more of into this push and pull between developers and what we want sort of as a global TB community from a diagnostic.
Fair enough. That's interesting to hear, and it must have been very interesting to see happening in sort of real time.
Yeah,
In
the
this
way the seminar ran, because normally
Mary, do you want to ask your question?
Yeah.
So
I had a question about the low sensitivity, high specificity screening test, because I think during the Delphi process, we had reviewed that. And I remember during our internal discussions, I was confused by how that worked. And I'm still slightly confused because if you have a very low prevalence and you have a test that doesn't have good sensitivity, so it's missing half the people who even have TB. I'm still struggling to wrap my head around how that works. Like for swab testing, I think the early data from swabs is that it's going to be, fairly low sensitivity, but if it's, it has pretty good specificity on PCR. So like if you think of like you do swab testing on everyone, I mean you would find some cases, but just how does that work out?
Yeah.
Sorry.
No, that is something we ended up chatting about quite a lot. I think in this case, we were thinking, if you could have some type of high throughput, perhaps maybe centralized test that could work where you could, collect swabs or samples from a lot of people that you otherwise would not be testing, I think, at all. So even in this case, maybe we wouldn't find everyone, but these people might not be tested otherwise. I think it was just also about, sort of broadening some of the test considerations.
Yeah, I think this was a lot of comments we got from David Dowdy, who was like, well, what if we had a test that had a sensitivity of 20%, but it was 50 cents. And you could just do it again and again and again, and eventually you find people. But so then the issue with that is making sure that the specificity is high enough that you're not running all these extra diagnostics and turning into a cost issue. And so during these discussions, it was about coupling the suggested price for a high specificity, low sensitivity test would actually also need to cost less than a high sensitivity.
Yeah.
So the sort of ideas people had in their mind about what these tests might look like and how they'd be used were differing. Yeah.
Okay, interesting. Yeah, it must have been really interesting to be in those discussions. And yeah, the constant like play, the back and forth between like the performance and the costs.
But like, how do you do this for screening? I mean, for real, like screen who, how, like all of this matters in terms of what the value should look like, but you also need a tool to start with. And so it's this weird chicken and egg situation. And so like the modeling was just a basis for discussion more than anything, because, you could make any kind of a test if you implement it in the right way. It could be cost effective. It could help you find more people. But you need somewhere to start.
Yeah.
These are really hard discussions because everyone was kind of just
Yeah.
Just kidding. Everyone was very sure. It was very reassuring.
Great. Thank you.
Thanks, Mary. Mama Puri.
Yeah, hi. Obviously, always great to hear your talk again. So I remember earlier on, I think one of the key like trade-offs that you're working around is access and accuracy. And I understand that for accuracy, it's more on the performance of the tools, right? So and then it's easier to parameterize in the model. So for the access part, what did you use or as a proxy, or if there was any way to represent that?
So in the end, our access sort of came down to looking at how a diagnostic might affect the patient journey, particularly in terms of like the number of visits they may need to make to come back, under the assumption that every time someone has to make a visit, there's potential for external barriers to prevent them from coming back. which means we may lose them through the diagnostic process and they may not make it all the way to the end and actually receive their results. So for example, if we had, currently it might be that someone goes to the facility, they get referred for testing, maybe they provide a sample, they have to go home again, a couple days later they come back and they get the results. There's a proportion of people we will lose there. Whereas if we had a rapid point of care, true point of care test, they could arrive at the facility, we could test them and potentially start them on treatments straight away. And similarly, in terms of sample type, for some people who can't provide sputum, it may result in, a lengthier process and a more invasive process to sort of get a sample for them. Whereas if we had like an oral swab, I think we saw in COVID, how easy it can be to sort of collect those, a large group of people. So our access came down to the type of diagnostic, I guess, in terms of its implementation.
And it also increased that, so if it was a non-sputum type, it also increased the likelihood that a provider would offer a TB test in the first place as well. So it does, so it's not like we're increasing the percent of facilities that would have access to a certain test, but more making it more accessible to reach your result in a way. The whole process to getting to that final result.
Like a tongue swab.
Yeah.
Brilliant. Thank you. And thank you, Mama Pudi. We have a couple of minutes left if anybody has any final questions. And if not, this is your last chance. In that case, thank you again, Alexandra. It was really interesting. And I think, I don't know, especially for me to hear about the sort of the process involved was really insightful and helpful. So yeah, thank you very much again. Just to say that we won't have a TB Max seminar in December, but we're coming back in January with some talks about drug-resistant TB treatment. I think that's the January one, and then we have a couple of other seminars lined up for February and March. But again, do let me know if you'd like to present anything or if you would like to hear from anybody on anything in particular. And yes, thank you again, Alexandra, for a great, really interesting presentation. Thanks, everyone.
Bye-bye.
Bye. Bye.